Good evening, ladies and gentlemen. Welcome to another recall class. I hope all of you are doing well. Hi, Dr. Simran. How are you? I'm good. Thank you so much. How are you, Dr. Midhead? Alrighty. So we'll be continuing the November recalls. I'm sorry about the last class being cancelled. I was remote on call and then I was called into hospital because the person called in sick. There's only 47 participants at the moment, so let's just wait a couple of more minutes so that everyone can join and then we'll start our class today, okay? All right, we have an appropriate number of people joining the class today. Let's start our class. So we will be continuing the November recall sample question. First question. A pregnant lady with GBS positive on urine culture on 12 weeks of pregnancy. She has been treated with antibiotics at that time. What further action will be required in the pregnancy? Antibiotic for the neonate, antibiotics during labor, perform vaginal swab for GBS or GBS swab again at 34 to 37 weeks. So we are having mixed answers, B and D. We know we don't do antibiotic for neonate unless we know the patient didn't have a GBS swab at all, or if we know that patient had a GBS swab positive at any time during the pregnancy but was not treated. Then we do antibiotic for the neonate. Antibiotics during the labor, this person has been GBS positive. Doesn't matter what time she was positive. If she is positive at 12 weeks, if she is positive at the normal screening time that we do, she will receive antibiotics during or 2 hours before labor. Basically, before the rupture of membrane, we give antibiotics, okay? Performing vaginal swab for GBS and GBS swab again at 34 to 37 weeks. Let me give you a clue here, guys. C and D are almost the same options they have given you. All right. Perform vaginal swab for GBS. One option. And then they're saying again, GBS swab again at 34, 37 weeks. If you see something like that in your exam, that means that those options are not correct. Okay. Once a patient who has become GBS positive at any time during her pregnancy, whether it was detected on a urine culture, whether it was a previous pregnancy, whether they have become positive at 34, 37 weeks, we treat them with antibiotics. So here, the correct option will be option B. Is it clear, guys? They have repeated the answer, the options twice. They have given you two options with vaginal swabs. If something like that happens during your exam, try to pick a more broader answer. So here they have said perform vaginal swab for GBS, and then they're saying again in option D, GBS swab again at 34, 37 weeks. Usually if a patient becomes GBS positive on urine, we don't repeat the patient's GBS swab at 34, 37 weeks. We don't need to repeat because this patient, once GBS positive in pregnancy at any time during a urine culture MCS, that patient will be treated with antibiotics at the time she was diagnosed with it, and she will receive antibiotics. Why we do the screening? What's the purpose of doing the screening? To picking out the high-risk pregnancies, right? Once you have a GBS positive on a urine culture in earlier part of the pregnancy, there is no point in repeating the test again, because doesn't matter whether the test is positive or negative, this person has been infected, has been colonized, so that means that we will give her antibiotics. Yes, if in previous pregnancy she was GBS positive, then yes, we will repeat it in the next pregnancy as well. And yes, we will give this patient antibiotics as well. To decrease, why we give GBS? To decrease the risk of neonatal sepsis. Why do we do GBS? To decrease the risk of neonatal sepsis. And number two, we need to decrease the risk of endometritis or postpartum complications in the females, chorioamnionitis and stuff like that. Okay. Intrapartum antibiotic prophylaxis is only effective in the prevention of early onset GBS infection, not the late onset one. CDC or FDA, ETG here recommends universal screening, rectovaginal culture between 35, 37 weeks. We all know that. Intrapartum antibiotic prophylaxis is recommended with positive GBS rectovaginal culture, GBS bacteriuria, which is positive in this patient at any time during pregnancy, or history of delivery of an infant affected by early onset GBS infection, meaning previous pregnancy infection. If GBS status is unknown, antibiotic prophylaxis is recommended during preterm labor and delivery, which is less than 37 weeks, in the presence of the maternal fever during labor, or with the prolonged rupture of membranes, which is then greater than 18 hours. IV penicillin G is the antibiotic of choice. If you can't give that, you can also give cefazolin, ampicillin, clindamycin, or vancomycin. Is it clear, guys? It's usually before rupture of membranes, Dr. Shabir. It could be early part of the pregnancy itself. Oh, sorry, early part of the labor itself, not during the delivery. The mother is pushing and you're giving her antibiotics. It doesn't happen like that. When before the rupture of membrane, she's contracting, you can start the patient on antibiotics. Clear, guys? Okay, next question. A schoolgirl came with her mother for abdominal pain. Girl said that GP's daughter is her close friend. What should the GP do in this situation? Option A, ask her if she is comfortable with the consultation. Option B, ask her whether her mother needs to leave the room. Option C, advise to see another GP. If the mother is positive with the GBS on urine MCS, then it's recommended to treat for 7 to 10 days with oral antibiotics. If she is septic, then she will require admission with IV antibiotics. It's a clinical decision. If it's a cystitis or bacteriuria, asymptomatic, usually 7 days. If it's a cystitis, 5 to 7 days. If it's clinical pyelonephritis, 7 to 14 days. Okay, so in this question, a schoolgirl, they haven't specified age, so schoolgirl will be from 9, 10 years onward. She's coming to a GP clinic with her mother for abdominal pain. The girl is friends with the GP's daughter. So most appropriate here would be option A. Very good. So ask her if she's comfortable to have the consultation. This is no wild, there is no, what do we say, conflict of interest here. Because you don't know the patient personally, it's your extended family's relations with the patient. If the patient herself or the mother herself is comfortable with the consultation, you should go ahead with it. Ask her whether her mother needs to leave the room, depends on the age. If she's a minor without GILEC competence, we don't need to do that, which hasn't been advised here about her age, so very bad option to pick. Advice to see another GP would be your next question if she is not comfortable with you having the consultation. So first option is whether she's comfortable to have the consultation. If she isn't, advise her to see another GP, or you can book an appointment with another GP in the same surgery. If she is doesn't want to be on the same surgery, you can book an appointment with another clinic as well. And if she's comfortable, then you can go ahead with the consultation itself. All right. Next question. A patient had suction, dilatation, and curettage for hydatidiform mole, and her beta HCG was dropping back to normal on monitoring. Few weeks later, it started rising again. What can be the reason? Invasive mole, choriocarcinoma, or pregnancy? Very good. The first thing we need to rule out is pregnancy. Hydatidiform mole, even though what advice do you know? Do you guys know what advice we should give to the patient after hydatidiform mole for not having pregnancy? How long they should not be trying for pregnancy? Do you know how long? No pregnancy for 12 months. So this is something that can happen if the patient is not following advice. So if the beta ECG started rising, rule out pregnancy first. Number two, what is the other thing that you want to rule out if the pregnancy is ruled out? For example, what can be the reason if pregnancy, let me just amend the question. If pregnancy is ruled out. Very good. Your answer will change. We need to look for choriocarcinoma. Most of the time, the monitoring after the hydatidiform mole with the beta-HCG is done for several reasons. After counseling the patient regarding the pregnancy, still they can get pregnant if they are on contraception, even through that, because no contraception is 100% other than the bilateral tubal ligation. So we need to advise them about pregnancy, and we need to advise them about choriocarcinoma as well, because hydatidiform mole increases the risk of the patient getting choriocarcinoma. That's why we do the beta-HCG monitoring. We rule out pregnancy and we try to see whether it's coming down and it's not going up for choriocarcinoma. So here, if the pregnancy is ruled out, we will go for choriocarcinoma. Very good. Do you guys want to have a read through this, or we can skip the trophoblastic disease? Skip? Let's see what everyone else say. Skip? Okay, everyone is happy. They know everything about it? Okay. Majority is saying skip, so we will be skipping. This is the RANSCOG guideline regarding the management of the trophoblastic disease. Just telling you, there is this one that I want you guys to have a look at. Okay, this one. Have a very good read of this. This is very important for your exam, okay? It solves a lot of questions. Have a good read of this flowchart. Okay. Next question. On popular demand, I'm skipping that. But if anyone wants to have a read of it, just let me know and we can do it at the end of the class. A patient with pain in elbow and more when extending against the flexed wrist. Tenderness in the lateral epicondyle region. There has been no comments made about the occupation of the patient. What is the instant most appropriate management? Option A, antibiotics. Option B, steroid injection. Option C, immobilization. Option D, orthotic band. And option E, long-acting anesthetic injection. So they are talking about lateral epicondylitis. For lateral epicondylitis, we usually give a orthotic band. Very good. So analgesia or an orthotic band and physiotherapy. We don't immobilize. We give a orthotic band, which is a band just above your elbow that helps to reduce pain when you're using your arm, because you can't immobilize the wrist movement. You're going to be using your hand. We don't immobilize, but we do give an orthotic band that helps to lessen the strain on the lateral epicondyle region of insertion of the extensor muscles. All right, have a look at this. Yes, most appropriate initial management will be analgesics. We all know about lateral epicondylitis. It's a aesthetospathy, meaning there is inflammation of the tendon insertion with the origin of the extensor carpi radialis brevis muscle. We know that the patient will always complain of pain when they are doing wrist extension against resistance. Sometimes most common use is that typing causes pain, writing causes pain, or extensive use, especially in tennis players, will cause pain in this region. Presentation is pain. What else? Pathophysiology we all know about. So you guys shouldn't remember the name of the test that is used for lateral epicondylitis. Most commonly used in clinical practices is Cozen's test, but there's a Maudsley test also used. So in Cozen test, what we do is it's the extension against resistance. So the patient stands with the affected elbow fully extended and forearm pronated. And then the clinician places his thumb over the lateral epicondyle region and asks the patient to clench their fist extend and pronate against the resistance. So that resistance will produce or reproduce the pain in the region where the thumb is present. Usually, we don't do X-rays, but ultrasound and MRI will give you an indication about radiological evidence of the disease. But usually, this is a clinical diagnosis. You don't need to do any imaging. If you're very concerned, you can do an X-ray to rule out fractures or osteoarthritis disease. Management, non-operative, very extensive literature is there, but few randomized controlled trials shows that they have been trying to do extracorporeal shockwave treatment, which has been not very effective. So physical therapy, injection modules, they are more promising than ESWT. Local illness, for example, they have conducted a randomized controlled trial where they have injected lots of agent, which showed better pain relief with steroids at 8 weeks compared with the local anesthetic at 24 weeks. So patients who are having prolonged disease, they can benefit from steroid injections every 6 monthly. GTN can be also used, but not very effective. But you can also give NSAIDs in relieving elbow pain in short term. Operative, especially in patients who are young athletes and are constantly using and they have pain, you can try to do surgery. But again, surgery itself have very consequences. Even though they are trying to fix the extensor carpi radialis brevis, they can cause injury to the surrounding muscles as well. What else? That's about it. Let me show you what the orthotic band look like. This is the band. This is how they wear it. And it helps a lot with pain management. Rather than taking lots and lots of NSAIDs, this helps a lot. Because this does not ask you to limit the or immobilize the joint itself. It helps to keep on doing the activity, but a controlled activity. This helps to minimize the pain after the pain. Alrighty. Next question, guys. Any questions? Yes, I will repeat it, doctor, about the trophoblastic disease at the end, okay? Any question, guys? Okay. A patient is coming with fever, headache, mild neck stiffness, clinical findings within the range. You have done a lumbar puncture and CSF findings shows that the pressure is normal, protein is normal, glucose is normal, there is very few red blood cells, and white cell count is 90 and the culture is negative for anything. What do you want to do from management perspective? Give the patient cefotexime, give penicillin, gentamicin IV, or give supportive or symptomatic management. Very good. So we all know these are the findings of viral meningitis and viral meningitis. Supportive symptomatic management is done, or you can give antivirals if you know what kind of virus it is. Have a look at the CSF findings, very important for your exam. So in a normal cerebrospinal fluid, appearance is clear, white cell count is negative, Predominant white cell is lymphocytes. Red cells are not present. Protein is normal, which is 0.2 to 0.4. Glucose is not present, and opening pressure is 10 to 20. In neonates, it's all the same, but more than 60% normal plasma cells are present. In viral meningitis, your white cell count will be minimally raised. Predominantly, they will be lymphocytes. Protein will be normal or raised. Glucose will be normal. Pressure will be slightly high, but not very high. In bacterial meningitis, it will be cloudy in appearance. Your white cell count will be very high. Predominant cells will be neutrophils. Your red cell count might be high. Protein will be high and glucose will be low, and your opening pressure will be very high. Fungal meningitis, especially in patients who are immunocompromised, there will be a fibrin web. White cell count, same as that of the viral meningitis. Lymphocyte predominant cells will be present. Protein will be normal or raised, but glucose will be low and opening pressure will be very high. Tuberculosis meningitis, predominant cells will be lymphocytes. Proteins will be very high, glucose will be very low, and pressure will be very high. Again, it's a bacteria, so cloudy and turbid appearance or viscous appearance will be there. Clear, guys? RBC positive doesn't mean it's encephalitis. If RBC is positive in CSF, then I will be very worried about whether there was a hemorrhage within the ventricles itself, like subarachnoid hemorrhage. Yes, or it will be traumatic. I agree with Dr. Urmi. So RBCs will be, if you see that throughout the CSF, you have xanthochromazia, that means that subarachnoid hemorrhage is there. But initially you had a bit of blood and then afterward it was clear, then it's traumatic tap. It's the same with the ascitic tap, or if you do pleural thoracentesis as well. Just give me a few seconds, guys. I'm just gonna grab my water bottle and be back. All right, let's go to the next question. I think this is a repeated question. A patient with a history of alcohol, smoking, coming with abdominal pain. Ultrasound shows there are gallstones in the gallbladder. Common biliary duct is dilated to 10 millimeter, but there are no stones in the common bile duct. LFTs are coming back to normal and the symptoms have resolved. What is the management? Do ERCP? Do cholecystectomy and intraoperative cholangiogram now? Go do a cholecystectomy later? Do a laparoscopic cholecystectomy with biliary duct exploration? All right, so majority are saying that we do a laparoscopic cholecystectomy with biliary duct exploration, which is the right answer. Now, because there is no stones in the common bile duct slash the LFTs are coming back to normal, they are not persisting or getting worse, and there are no signs of cholangitis, we will not do ERCP. This is biliary colic. Patient is having biliary colic, so we need to do and the common bile duct is dilated with the biliary colic. So most common approach towards a biliary colic is we take out the gallbladder and we do an intra-operative biliary duct exploration just to figure out why the CBD is dilated. Best approach is laparoscopic. We don't do an open surgery. ERCP is done in patients who are having acute cholangitis, patients who have choledocholithiasis, okay? Or gallstone pancreatitis. So this is just for you, for your information. If liver function tests are normal, this will be done at elective because the patient's pain is resolved and patient's liver function tests are improving. It will be a day surgery. It will not be an emergency surgery. If liver function tests are normal and bilirubin is normal with the common bile duct dilation and gallstones, we do a lap chole with intraoperative cholangiogram / exploration. This is the same thing. If the liver function tests are abnormal and there is common bile duct dilation with gallstones, then we do MRCP to rule out choledocholithiasis. And if choledocholithiasis is present, then we do ERCP. Otherwise, we do lap chole. Is it clear, guys? MRCP done is here. Or when there is contraindication to do ERCP, you can do MRCP. ERCP is diagnostic and therapeutic. MRCP is just diagnostic. If the stones are present in the common bile duct, then you can do it. Here they are saying if liver function tests are abnormal with the common bile duct dilation and gallstones, they're not saying that the gallstones are present within the common bile duct, gallstones within the gallbladder, then MRCP to rule out. If you are confirmed that there is common bile duct with stones inside, then you do ERCP. You don't need to do MRCP just to rule it out. If ultrasound is convincing enough that your common bile duct is dilated and there is a radiological evidence or patient is developing acute cholangitis, you don't do MRCP. You straight away do ERCP. Clear, guys? Yes. If stones in CBD but no acute cholangitis, do we still do ERCP? Yes. Gallstones in gallbladder with common bile duct dilated but no gallstones, we don't do ERCP. Yes, in choledocholithiasis, you will get cholestasis picture of the liver function test. Clear, guys? Okay. Any questions regarding this? All right. Next question. A patient with hematuria, proteinuria, cough, hemoptysis, has purpuric rashes and diplopia along with oral ulcers. What is the diagnosis? Wegener's granulomatosis, Goodpasture syndrome, IgA nephropathy, or renal cell carcinoma? Alrighty. So this is vaginal granulomatosis. If a patient is coming with um, hematuria, hemoptysis, purpuric rash, and oral ulcers, always think of vaginal granulomatosis. Goodpasture syndrome will not have purpuric rashes, diplopia, oral ulcers. They will have hemoptysis and hematuria, kidney and lung involvement because of the anti-glomerular basement membrane antibodies. This is vaginal granulomatosis. IgA nephropathy, patient will present with hematuria and hypertension. Renal cell carcinoma in males, they usually present with chronic low back pain, weight loss, night sweats, anemia. And if it's a left-sided renal cell carcinoma, they can also present with varicocele as well and lymphadenopathy as well. Clear, guys? I am never able to remember this, but this is just for your information. So, vaginal granulomatosis, it's a ANCA vasculitis. It can affect skin, joints, kidneys, lungs, heart, neurological symptoms, and your eye as well. Can cause otitis, vestibular, auditory, neuritis, and nerve injury. It can affect your glottis region, causing subglottis stenosis. It can cause endobronchial stenosis. In your heart, it can cause inflammation of all of the layers of the heart. In your eye, it can cause inflammation. It's basically inflammation of every part of the body. So it can cause inflammation in your lung, leading to upper respiratory and lower respiratory tract symptoms like rhinitis, sinusitis, septal perforation, saddle nose, nasal ulcers. These are the upper respiratory tract symptoms. In your lower respiratory tract symptoms, you will have cough, dry, shortness of breath. Patient can have pulmonary infiltrates, nodules, pleurisy symptoms, chest pain. And your kidneys will be inflamed, so you will have glomerulonephritis. Your muscles will be inflamed, leading to myalgias. Your joints will be inflamed, leading to arthritis and arthralgias, and there will be peripheral neuropathy as well, and skin lesions as well. So ANCA, usually cytoplasmic pattern with the NTPR3 antibodies. It's a triad of upper respiratory tract, granuloma, pulmonary nodules, and glomerulonephritis. That is very uh, that's a very good way of summarizing all of the symptoms, that it can affect every part of the body and cause inflammation, but most commonly presenting symptoms are kidney symptoms and lung symptoms, and upper respiratory lung symptoms and lower respiratory lung symptoms as well. Renal cell carcinoma usually presents with low back pain, weight loss, and night sweats. If you have a renal cell carcinoma of the left side in males, it will present with varicocele as well. Yes, painless hematuria and renal cell carcinoma as well. Yes, thank you so much, Dr. Sonera. Clear, guys? Any question? All right, let's move on. A patient is presenting to you with a painful left axillary lump of 1 centimeter. Recently had a COVID vaccine and have mild swelling and erythema on the left arm. Also have history of breast cancer on the right side 10 years ago. So meaning patient is in remission. Otherwise, normal findings. What is the diagnosis most likely? Hidradenitis suppurativa, reactive lymphadenitis, metastatic deposit, or lymphoma. All right. So Patient is presenting with a painful, isolated lump. Very small lump, 1 centimeter. Recent had COVID vaccination, and there is a mild swelling and redness around the area. History of breast cancer, but is in remission. So most likely because of the recent COVID vaccine administration, patient can have reactive lymphadenitis. Very, very common after COVID. Any kind of vaccination in which is intramuscular, it's very common to get reactive lymphadenitis. Metastatic deposit could be there, but if patient didn't have wasn't in remission or didn't have COVID vaccination history as a trigger, then I would pick the metastatic deposit as the next best option because of the history of the breast cancer. Hidradenitis suppurativa, it's not an isolated lump. It's like lots of lumps in the area where the hair follicles are, and they will all be abscesses or furuncles or carbuncles. Lymphoma, isolated lump is not most likely lymphomas, and they are painless lumps. They are not painful lumps. And if the COVID vaccination was not there, breast cancer history was not there, but painless lump increasing in size with constitutional symptoms of malignancy, then you consider about lymphoma. And lymphoma lumps are most common in the cervical areas. It's more common in the neck instead of in the axilla. If it's in the axilla, I would be more concerned about breast cancer. Clear, guys? So this is what hidradenitis suppurativa looks like. So wherever you have hair follicles, there will be painful lump in their skin. It's basically infection of the hair follicles. Patients are on antibiotics and under dermatologists for the treatment. Reactive lymph node is a lymph node that is swollen in response to some kind of infection or other condition, especially post-vaccination. Lymphoma lymph nodes are not painful, and metastatic lymph nodes initially are not painful. But this should be your second best option if they haven't given you a trigger like COVID or like recent infection on the background of breast cancer. Clear, guys? Any question? All right. Next question is, a child with bleeding gum, epistaxis, and multiple petechial lesion in the leg and trunk. Recently had a upper respiratory tract infection. Platelets are 90 into 10 raised to power 9. Other parameters are normal. What is the treatment of choice? Corticosteroid, platelet transfusion, or observation and follow-up? Okay. All of you are saying C. Let's have a look at the guideline. What does Royal College of Physician and Surgeon tell us to do? Oh, I opened too many. Okay, we all know this is ITP, which is immune thrombocytopenic purpura. It's an isolated low platelet count of less than 100 in an otherwise well child with a normal full blood count and film. Other causes of petechial purpura you need to rule out. Decision to treat should be based on clinical symptoms and not the platelet count. Okay, so let's see when we need to treat the patient. If the patient has petechia and bruises, there is painless oral petechia and purpura, blood crusting in nares, but not active bleeding. Oh, sorry. You don't need to treat it. Outpatient follow-up with the patient. You repeat the full blood count and review in 1 week. So you just observe the patient. If there is epistaxis or hematuria or hematochezia or painful oral purpura with significant menorrhagia, so active bleeding, often requires hospital admission, should be reviewed by hematologist. Patient should be given oral prednisolone. If poor response, can be given IVIG as well. If active bleeding is there, you need to control the bleeding with oral tranexamic acid or IV tranexamic acid, or manage the heavy menstrual bleeding with tranexamic acid and mefenamic acid. Tranexamic acid must not be used if hematuria is present. If you are suspecting internal hemorrhage, like in brain, lungs, muscle, joints, or mucosal bleeding that requires immediate intervention and it's not being controlled by above mentioned measures, then you need to give IVIG combined with steroids, or you need to give patient platelet transfusion, and you need to give patient IV tranexamic acid. And if there's internal bleeding, surgical intervention is required urgently. Okay? Now you look at your question and please tell me the answer. Child is coming with bleeding gum, epistaxis, multiple petechial lesions in leg and trunk. Recently had an upper respiratory tract infection. Platelet 19 to 10^9. Other parameters are normal. What is the treatment of choice? Very good. We'll start with steroids. This is the moderate group. Very good. So your symptoms will tell you about the treatment, not the platelet count. The platelet count should be isolated thrombocytopenia. You need to make sure of that. If patient is bleeding, but not severely bleeding, and there is a bleeding from the mucosal surfaces, especially like epistaxis, hematuria, menorrhagia, then you can start the patient on oral steroids, or if the patient is not responsive, IVIG. But if there is internal bleeding, and it's not being controlled despite being on, or sometimes they can say, oh, patient was on steroids, have internal bleeding now, what to do? Then you start the patient on IV steroids, IVIG, you give platelet transfusions, and urgent surgical intervention is required. Clear, guys? Yes, if you have a look over here, where is the guideline? So suspected internal hemorrhage or mucosal bleeding that requires immediate intervention. If you go through the content, they will say the patients who have had these but not bleeding is not controlled, then combine IVIG with the methylprednisolone for 3 days, platelet transfusion, continuous if required, IV tranexamic acid, and urgent surgical intervention. So you need to do all of these. Combine the IVIG and IV steroids, do the platelet transfusion, give tranexamic acid IV, and urgent surgical intervention. All right. Any question, guys? All right, let's move. A mother came with child for vaccination, complains she has sleep disturbance due to frequent crying of baby, and husband is not supportive at all. Despite this, she can do work and interact with colleagues as usual. What is the initial step in management? Send a nurse for home assessment, refer to Marshall Relationship Council, or sleep hygiene and partner support. Okay, we are having mixed answers. Mother is coming with, so this is a new mother who's coming with the newborn. She complains she has sleep disturbance because of the frequent crying of the baby. Husband is not helping. She is otherwise functioning well. She can do the work. She can interact with the colleague. There is no concern for postnatal blues or depression here. Send a nurse to home for assessment. It's not usually the first step we do for a patient who is coming with sleep problems or postnatal blues problems or depression problems. We don't send a nurse to home for assessment. Usually after the baby is born, there is an initial nurse visit and then a doctor's visit at 6 weeks' time. Marital relationship counseling is not required. Sleep hygiene, we need to focus on the patient. We need to speak to the patient about sleep hygiene, and then you can counsel the patient about this partner support. Okay? How you can do that is, if you send the patient to marital relationship counseling, you're just getting rid of this patient instead of actually helping the patient out with her problems. Partner support is a kind of counseling that is done in GP setting, where if a patient is having problem, for example, this mom is having problem because the husband is not cooperating, what we can do is we can ask the husband to come on the next visit, and then we can, instead of picking out that, oh, you're not supporting and you're not doing this, we can counsel them about sleep hygiene with the new baby on board. Are you guys getting what I'm trying to say? Look, what we usually, in my opinion, I would select C better, because in this way I will be able to assess the husband as well. Nurses usually come initially when the mom and baby are discharged from the hospital. Then in 2 weeks' time, then the nursing staff comes to assess the patient. And then the patient has a visit with the doctor in 6 weeks' time. If he is non-cooperative and doesn't come at all, then we can refer them to Marshall Relationship Counsel. But first, we have to try to sort out the problem of the sleep disturbance. No, I don't have any reference for this case. I'm sorry. This is my opinion. It's the midwife that comes for the baby assessment and the mom. We had a baby crying just now. So what happens is that when a mother is discharged from the hospital with a newborn baby, there is a midwife visit at 2 weeks' time, and the midwife goes to home, looks after if the mother is coping. The midwife is usually the first person of contact that will assess the home situation and whether the baby is gaining weight or not, and if the mother needs help with anything. Then the midwife can do a discharge summary that goes to GP, and she will point out the steps like, oh, patient is having concerns with this and this, and you can kind of proactively make a plan before seeing the patient about how to target the specific concerns of the patient. When the patients visit you on 6 weeks' times or on vaccination and is complaining that she's having sleep troubles and husband is not cooperating, then in this case, we don't know what is the reason the husband is not supportive at all. She is not having problems of postpartum blues and depression. First thing is, she's having sleep disturbance. Counsel her regarding the sleep hygiene, and then we can do the partner support as well. This is my opinion. Okay, guys? If the mentors are having conflict between, especially ethics question, we can always ask Dr. Arshan to give us his insight as well, because he's much more experienced than us, obviously. Okay, so there is a question. Mother of 6-month-old, only sleep 2 to 3 hours a day, father alcoholic, doesn't care what to do. Yes, that will be community nurse visit. I would agree. So the question here is this one. Oops. Just give me 1 second. I'm going to post the question that was discussed previously in another one. Just give me 1 second. So this was the question discussed by the previous mentor. Is this the one? are you guys talking about? Partner support program or partner support counseling is what the GPs do. If the spouses are having trouble and they come to their GP, you can help them to sort it out before sending them to a counselor. Sometimes people can't afford counselors and they are not covered by Medicare. So GPs are the first doctors to help you sort this kind of things out. In here, I would definitely pick this one because the dad is an alcoholic. Okay. 6-month-old, only 2 to 3 hours sleep. Father is alcoholic, doesn't care what to do. So here, what the problem is, alcoholic parent is there. Substance abuse inside the house is there. Now there is a risk for child abuse or the child safety is a concern. You can ask the community nurse to visit home, or I don't think so. It's a better option to call the husband. This is important, or if you can ask the mother about the safety of the child and ask the child protective services there. Non-cooperative, oh, for example, Dr. Siddha, if I'm your husband and the baby's crying, I'm not helping out and I'm playing on the mobile phone or I'm just doing my work, this is non-cooperative husband. I'm not being cooperative to you in taking care of the baby, even though that is my child as well. I'm one of the parents. All right. In another question, mother of 6 months old, not getting enough sleep because she's taking care, and father is alcoholic. Now, there is a concern for child safety here because there is substance abuse inside the house where the child is, and it's a very young child. Asking one of the nurses, so the community nurses, it's not like a midwife. These are the nurses that can do home visits, and they are either associated with the GP practice or they are associated with the Queensland Health Program of community nurses, where if the GP calls them, they can go and visit a patient and assess the situation and let you know whether you need to visit the patient or that patient needs to go to the hospital or an ambulance needs to be called. This is a community nurse's job essentially. So asking the community nurse to visit home in this situation will assess the home situation basically to see whether the child safety is a concern or not, or whether this alcoholic father needs to be removed from the situation or the child needs to be taken out of that environment or not. If there is no concern for child safety, then go to target the concerns of the mother. If child safety concerns are there, please ask one of the health care worker to contact the said home. I would not even ask the community nurse to visit home. I will ask the child protective services to go and have a look in this case, because the alcoholic father can also compromise the safety of my staff. So I will always send people with more experience in this regard. All right. Let's do 2 more questions and then we can go on a 10-minute break. Patient is coming with abdominal pain after taking ibuprofen for 4 weeks. He's a smoker as well, drinks 2 glasses of wine per day. He's febrile, there's abdominal rigidity and guarding, pulse is high, liver function test and lipase are normal. What is your diagnosis? Very easy question. Acute pancreatitis, acute cholecystitis, or peptic ulcer perforation. So we all know a patient who is having abdominal rigidity and guarding with abnormal vital signs, especially tachycardia, tachypnea, hypotension. Higher suspicion of peritonitis or perforation should be there. They have given us a history of ibuprofen use for 4 weeks. So patient is having NSAIDs chronic use. Smoker drinks 2 glasses. So smoking is there. Alcoholism is there, is febrile now. So peptic ulcer perforation most likely would have happened. They have also told you that lipase and LFTs are normal. So acute cholecystitis and pancreatitis are ruled out. This is peptic ulcer perforation. What is the first imaging that we do for a perforation to rule out a perforation? Erect X-ray, not just X-ray, guys. Erect chest X-ray. Abdo X-ray, chest X-ray. As long as your diaphragm is visible, it has to be a erect X-ray. All right. I'm not going to go in the details of this. We are going to skip because everybody knows about this. So what is the treatment of the peptic ulcer disease or peptic ulcer perforation? What is the first line management? Nil by mouth, IV fluids, PPI, very good. Nil by mouth, IV fluids, PPI, and then laparoscopic laparoscopic laparotomy. You see where the ulcer is and you try to fix it. Antibiotics as well, very good, doctor. We give broad spectrum antibiotics. It should be an erect X-ray. Chest, as long as the diaphragm is visible, it's fine. It can be a chest X-ray, it can be an abdominal X-ray. As long as the diaphragm is visible, it needs to be an erect X-ray. Otherwise, you won't be able to see any air under diaphragm. The next thing that you can do is a CT scan with contrast. Okay. 50 years old lady found out that she was adopted and her biological mother had Huntington disease. She is requesting for genetic screening. What is the best next step? Tell her disease is unlikely at this age or refer to genetic counseling. So we all know any patient who is above 18 is requesting for a genetic screening. We refer them to genetic counseling first, and then they can organize genetic screening and see whether the patient is, whether they can have the screening on Medicare. Okay, basically free of cost. They have to see the eligible criteria. So this is the genetic screening counseling. It's done by a separate group of people. You guys can have a look over here. Let's take a 10 minutes break and then we can be back and we'll finish this recall session. Okay, guys, 10 minutes. All right, guys, let's start again. Are you guys able to see the screen? Okay. Next question. A mother is coming with 12-year-old child requesting screening for familial hypercholesterolemia, as her father recently got diagnosed to have that, and there are other members of the family with the premature heart disease. What is your next best action? Do a lipid profile for the 12-year-old, screen the whole family, screen the daughter, say that daughter is not eligible now. Okay, have a look at this, guys. So this is the clinical criteria for familial hypercholesterolemia. Your first degree relative has a premature coronary artery disease or vascular disease, or a relative is having LDL level above 95th percentile. It has 1 point. First degree relative is having signs of familial hypercholesterolemia, which is tendinous xanthomata or arcus cornealis, or children less than 18 is having LDL level above 95%. Then you do clinical history. Patient is having premature coronary artery disease or patient with premature cerebral or peripheral vascular disease. They have certain points. Physical examination, tendinous xanthomata or arcus cornealis before 45. They have different points. You need to have cholesterol levels. DNA analysis you can do. And diagnosis is based on the number of points. If more than 8, definitive diagnosis, 6 to 8, probable diagnosis, 3 to 5, possible diagnosis, less than 3, unlikely. So what are we missing in our patient? We are missing the LDL level, right? So we need to measure her lipid profile in order to categorize her according to Dutch score. And we need to do the clinical examination and get history as well. So 12-year-old is presenting with the grandfather who is which is not a first degree relative, second degree relative, and other members of the family with premature heart disease. So you need to fulfill the criteria in which you have family history, you need to have clinical history, physical examination, cholesterol level, DNA analysis is plus minus, okay? At least till here, you should have all of this before telling the patient whether they are familial hypercholesteremia or not, or when they are scoring high, then you can screen the rest of the family as well. Even if it is the child's father who has been recently diagnosed, you still need evidence, clinical biochemistry evidence, right? Even if there is a first degree relative, you do need the familial history, you do need clinical history, you need physical examination evidence, present or not, and then you need a lipid profile. So we will do lipid profile, and then if the patient is scoring high for possible and probable one, familial hypercholesterolemia, try to screen the whole family as well. You need to do the scoring system. It's called Dutch Lipid Clinic Network Diagnostic Criteria for Familial Hypercholesterolemia. Clear, guys? It's raining a lot here. We are having a thunderstorm right now. All right. Is it clear? Any question? Is there a age limit? What sort of age limit for investigating? If there is concerns, then you can investigate in an early age as well. Familial hypercholesterolemia will present in an early age. Young population. Doesn't say anything about the age. How early? It's an opportunistic screening. So if you think that the patient has history and has red flags for familial hypercholesteremia, then you do it early. But in child, I have no idea how early you can do. But if the mother, for example, if any one of the family is an adult, you can do the screening. Children less than 18 years of age, you can do screening as well. But you need to have the red flags in those children's family, like first degree relative with a known premature coronary artery disease or LDL more than 95. And then you have early deaths because of the cardiovascular event, physical examination in those family members or in the patient itself of the hypercholesteremia. And then if those are present, then you can do the investigations in less than 18 years old as well. A patient tried diet management for 1 year, but no use. BMI 32, no other issue. What do you want to do next? Number one, refer to a dietitian. Number two, graduated exercise program. C, metformin. D, bariatric surgery. So BMI of 32 doesn't qualify for bariatric surgery at all. Can qualify for metformin. You have already tried the diet. Now the next thing is you try diet with exercise. Combining the diet with exercise will show results in weight loss. If the patient is not responding, then you can try pharmacological treatments as well. Yes. Have a look over here. Is it clear, guys? This is how the obesity is managed. Zoom, zoom. Okay, makes sense? All right. Next question. Sorry, let me just close this up. This is a very easy one. X-ray of a child who swallowed the coin. Coin is present in the upper part of the esophagus. Child is presenting with dysphagia symptoms. What is the management? You observe, do endoscopy urgently, or do serial X-rays? Symptoms of dysphagia. What do you do? Urgent endoscopy. What else needs urgent endoscopy in a child with a foreign body? Can anyone tell me? What sort of foreign body needs urgent endoscopy? Battery, very good. Magnets, very good. Battery and magnets, they need urgent endoscopy. Very good. Foreign body, Red flags or high-risk foreign bodies. These are button batteries, which are lodged in the esophagus. Magnet with a metal object or more than one magnet. Sharp objects in the esophagus, for example, like a fish bone, pins and needles. Lead-based objects that fail to transit through the stomach. Large object more than 6 centimeter or more than 2 centimeter wide. Expendable foreign bodies like polymers or water beads, especially multi-component objects like toys with different parts, objects that is impacted in the oropharynx. They all are the red flags and require urgent ENT or endoscopic removal. Airway compromise, also one of the indications in drooling, abrasion, ulceration. Magnet can perforate. Respiratory distress, these are all the urgent intervention sign and symptoms or red flags. Investigation, you can do imaging. Treatment is, if you suspect a foreign body to be present, high risk or unknown foreign body, high risk foreign bodies are given over here. And child unwell or has acute symptoms of pain, drooling or respiratory distress. Child has or had GI abnormalities. Unreliable history, food bolus not passing spontaneously, not able to drink or eat. Then foreign body, you can do imaging. You can't see it. Child looks well discharged. You can see it, but it's in the stomach. Then it's a low risk foreign body. Then you can discharge with advice. But if it's in the stomach or beyond, it's a high risk foreign body, urgent referral for removal. Foreign body in the esophagus, upper respiratory obstruction or high risk foreign body, urgent removal. Lower obstruction or low risk foreign body, you can discuss with the gastroenterologist about the management or consideration of a outpatient scope or a non-emergent scope, okay? Clear, guys? Any questions? Okay. Next question. It's a term pregnancy. Lady is coming to you with regular contractions, but her liquor is meconium stained. CTG shows that the baby's heart rate is 110. Baseline is 8. There are no decelerations. Accelerations present, cervical dilatation 3 centimeter. What next? Augment labor, emergency cesarean, or continuous CTG monitoring. Okay. Some people are saying augment the labor. Why do you want to augment the labor? There is no sign of fetal distress other than meconium stained liquor. If CTG shows with the meconium stained liquor that there is signs of fetal distress, go for emergency cesarean. Have a look over here, guys. It's not an indication for cesarean section. It's an indication that you need to be very vigilant now. Any changes in the CTG, you can change the management based on that. Yes, duration of the labor onset is not mentioned here. If it was prolonged labor, patient has been contracting for a while, and CTG is still normal, but meconium stained liquor, you can think about augmenting the labor. But still, we do continuous CTG monitoring. Clear? Yeah, we can wait. CTG is okay. We can wait. We can wait for nature to take its course. If after certain time there is no progress of labor, Yes, you can augment the labor after discussing with the patient. Okay. 37-year-old lady presented with amenorrhea, no other symptoms. Examination is normal, had normal vaginal delivery last year, and secondary PPH of 900 mils due to retained cotyledon, which is retained product of conception. And then later on, she had dilatation and curettage. Reason for her amenorrhea is which of the following? Option A, pituitary necrosis. Option B, intrauterine adhesion. Or option C, premature menopause. So this patient is having Asherman syndrome, which is intrauterine adhesions. Can anyone tell me what happens when there is massive PPH and patient presents with amenorrhea later on but didn't have any intrauterine instrumentation done? And patient can't lactate. Very good. Sheehan syndrome, pituitary apoplexy. Two things, Sheehan syndrome and Asherman syndrome, you need to remember about what is what. Okay. Oh, we can stay. Okay. Okay. Asherman syndrome, intrauterine adhesions or SNCI occurs when scar tissue forms inside the uterus and the cervix because of instrumentation, especially after surgery of the uterus or after dilatation and curettage, with tuberculosis, schistosomiasis being a less common cause. History, patients with Asherman syndrome may present with light or absent menstrual period. Some can have normal periods based on the surface area of the cavity that is affected. Pain may indicate endometrial buildup that is occurring during the cycles. Adhesion can present as recent miscarriages or infertility due to deficient endometrium or poor vascularization as well. So for the treatment is that adenolysis is basically the treatment. That's about it. And then Sheehan syndrome is when there's anterior pituitary gland is damaged due to significant blood loss. Clinically, this happens after delivery when there is a massive PPH and there is reduced blood supply leading to pituitary apoplexy. And then it leads to hypopituitarism, which is basically you can't have lactation, you can't have periods, you can't have stress hormones, hypothyroidism happens. So patient can present with fatigue, bradycardia, hypertension, weight gain, constipation, amenorrhea, leukomenorrhea, hot flashes, decreased sex drive, unable to lactate or agalactorrhea, hypoglycemia, hyponatremia, and anemia. Okay? In Sheehan syndrome, you replace all of the hormones. It's basically a hormone replacement therapy happening. Clear, guys? Any question? Sheehan syndrome is pituitary apoplexy. Asherman syndrome is the adhesions.
What are the drivers?
Yeah.
This one is not Sheehan. This is Asherman syndrome.
See?
Guys, can you please mute yourself? Okay. 14-year-old kid Knee pain, difficult to walk. X-ray left shows slipped epiphysis. What is the most appropriate management? Bed rest, exercise, or pinning? You will definitely have a question from slipped capital femoral epiphysis, tenosynovitis, slipped capital femoral epiphysis, tenosynovitis. There's another one that I'm missing. What's the name? Perthes disease. Yes, you will get a question, definite question from any of these. Developmental dysplasia of the hip, yes, sometimes, but definitely from Perthes, tenosynovitis, or slipped capital femoral epiphysis, septic arthritis, you will definitely get a question or two from there. So this is slipped capital femoral epiphysis, very common in pre-pubertal or pubertal boys, especially who are obese. They will present with hip pain or knee pain. And when you do an X-ray, the femoral femur is basically slipped. So usually when you draw a line from the neck of the femur, it usually passes the head of the femur, but in slipped capital femoral epiphysis, you will go above the head. It's a orthopedic concern. So what you need surgical intervention to correct it, because if you don't treat it, it increases the risk of joint instability for the rest of the life. And patients with slipped capital femoral epiphysis are at higher risk of having early onset of osteoporosis as well. SCOFI, you can study from orthobullets if you like, or you can study from JM. Both have same information. No, there is no bilateral SCOFI in the X-ray. It was unilateral. Okay. It's similar to Salter-Harris type 1 fracture, associated with hypothyroidism, renal osteodystrophy, growth hormone deficiency, panhypopituitarism. Can happen in child less than 10 years of age, but most commonly in prepubertal boys with obesity. Stable, unstable, acute, chronic, acute on chronic. History, most commonly presenting symptom is pain in hip, groin, and thigh, knee pain as well, or gait defect. Physical examination, antalgic gait, waddling gait, abnormal leg alignment, external rotation leads to foot progression in the angle. Drehman sign can be there. If you externally rotate, the foot externally rotates when you do passive flexion of the hip, or the hip externally rotate. Imaging, you can do AP and frog leg lateral of the both hip. This is the Klein line that we saw. So if it goes past the hip, the femur head, it's the Klein line. If it goes if the head is inside the line, then it's normal. MRI you can do as well, but not really indicated. You can diagnose with X-rays only. Needs percutaneous in situ fixation or open reduction, whatever, but it needs surgical intervention. Clear, guys? It's not bilateral, it's unilateral. Here. Okay, next question. Motor vehicle accident, 6 centimeter fracture and laceration in the leg. Which of the following is the initial step of management? X-ray, antibiotics, wound debridement, tetanus toxoid, or wound lavage? Okay. Have a look at this one. So open fracture, this is the stepwise approach to any open fracture. You remove gross contamination from the wound, okay? Provisional irrigation or debridement should be avoided. You just remove the dirty things. Take photographs and cover with the wet sterile cover. Start patient on analgesics. You can reduce the fracture or just gently align it under analgesia. IV antibiotics, tetanus prophylaxis, then X-rays, and then orthopedic urgent referral for operation for surgical wound debridement and definitive treatment of the fracture. So wound debridement is not done in emergency department. With the open fracture, we only do the first 7 things. Now you've read the 7 things. Which one would be the first one here? Antibiotics. Clear, guys? Is it clear? So this is the stepwise approach. Always remember that. Take a picture, Dr. Noor. This is the stepwise approach. It is confusing, but always remember. So for example, if there is a open fracture, remove any gross contamination, take pictures, start giving analgesia, IV antibiotics, tetanus, X-ray, and then wound debridement in fixation with the orthopedic surgeon. No, wound lavage is irrigation. No, we won't do. Provisional irrigation or debridement should be avoided. We don't do wound irrigation in emergency department. Try to remove everything from it. Gross contamination remove, analgesia, photographing, antibiotics, tetanus, X-rays, and then you can send him to OT for wound debridement, lavaging, fixation. Oh, if the patient has compartment syndrome, you do fasciotomy then and there. B is the answer. Initial management, they have asked. B, guys, B is the answer, antibiotics. This is not the option from, I took this from Emidex for your, these things. Should I just crop it so that you guys, there you go. Better now? It was just a question, another question whose answer has these steps. I wanted to convey these steps to you guys. Okay, next question. We only have 15 minutes left. Let's do this quickly. A patient is presenting with dyspnea. Full blood count shows hemoglobin of 60, platelets 80, white cell count is normal, MCV is slightly raised, liver function test is normal, but blood film show teardrop cells. Which one will give you further diagnosis? Direct womb test, CT scan of the abdomen, serum electrophoresis, ultrasound, we don't know where to do the ultrasound, or bone marrow biopsy. Can anyone tell me what does teardrop cells indicate? Do you guys know what teardrop cells indicate? Do you guys know when teardrop cells happen on So teardrops, red cells, it reflects altered bone marrow architecture, basically. Myelofibrosis. So if you have a myelofibrosis, what would you do? What is the thing that will give you the diagnosis? You will do bone marrow biopsy, right? So direct comb test, it's not going to give you answer unless you're thinking of hemolytic anemia, right? You don't have evidence for hemolytic anemia here. Hemoglobin is low, platelet is low, white cell count is normal, MCV 110, LFT is normal. They have not given you any information about hemolytic anemia, so you don't do Combs test. CT abdomen or any kind of imaging, what are you looking for? Are you looking for cancer? What sort of cancer? What sort of cancer has teardrop cells? Myelofibrosis, metaplastic neoplasia of the bone marrow. Serum electrophoresis, we usually do for thalassemia or multiple myeloma. Multiple myeloma doesn't have teardrop cells. It doesn't show history of thalassemia. Thalassemia is MCV should be low. So our answer is bone marrow biopsy because teardrop cells indicate architectural change in the bone marrow or myelofibrosis, basically. So definitive diagnosis can be done with bone marrow biopsy. Have a read of this article if it's not clear to you, but you guys should be aware of what is the indication for teardrop cells in your blood film. A history of MI. Patient is on aspirin, coming in for a routine checkup. Examination is normal. Found that cholesterol is high, 5.5. What is the most appropriate action? Very easy question. Start ACE inhibitors or just ACE. Didn't even say inhibitors. Add clopidogrel or add a statin. So we will start any patient who had a MI, doesn't matter normal cholesterol level or not, always start them on simvastatin because MI did happen because of the atherosclerotic block. I'm just trying to look for the paragraph that says statin. Sorry, give me 1 minute. This one. Clear, guys? Doesn't matter if they're give drug therapy. Sorry, I was just looking for this. There's a lot of literature I had to go through. Alrighty. Next question. Junior medical officer had a needle stick injury. Patient is a IV drug user. Junior medical officer had hepatitis B vaccination, but never got his hepatitis B antibodies checked. What is the next step? Check hepatitis serology. Give him immunoglobulin with vaccine or PEP for HIV. Yes, check the serology. Good. If the antibodies level is less than 10 international units, what to do? Yep, immunoglobulin and vaccination. If more than 10, you don't need to do anything. Okay, next question. 16 years old is coming with 4 months duration of recurrent headache and vomiting. Mother was diagnosed with brain tumor at 60 years of age and uncle had an aneurysmal rupture. What is the most appropriate management? So chronic headache history, vomiting, recurrent headache, high risk history. Follow up and observe, MRI brain, CT brain, or reassure. Okay. Oh, where did I open it? Okay. Headaches in kids and adolescents. Very common presentation. Most of the time it's benign, but you need to develop a pattern and see whether this needs imaging or not. Assessment, we know what kind of headache, Socrates of headaches you need to do. Acute, recurrent, chronic, non-progressive, mixed type. Imaging. You can do CT scan or MRI. Okay. Indications, acute headache, worse headache, chronic progressive, focal neurological symptoms, papilloedema, abnormal eye movement, hemiparesis ectasia, abnormal reflexes, neurocutaneous syndrome, headaches with vomiting on awakening, unwavering headaches. They require imaging. And the first imaging in not a very young child, is 16-year-old, you can definitely do a CT scan. Very young child, try not to do a CT scan. MRI will be good. What else? That's about it. So it's not a very young kid. In teenagers, you can do CT scan, guys. Aged, let's have a look. MRI brain, age indication. Ten or less. No, the answer is CT scan, guys. 10 or less, you need to do an MRI. I'll write it here as well. Not contraindicated. Teenagers can tolerate it. It's not readily available, Dr. Urmi, but 10 or less can't tolerate the radiation exposure is very high. 10 or less, it's what they said on Radiopedia anyway. But 16 or above, or in teenagers, basically, they say it's okay to do CT brain as a first imaging for headache. Let me have a look as well. Imaging for head. CT scan. Yeah, that says CT scan. If younger than MRI. Okay, Next question. Pervaginal spotting, 6 weeks gestational period, coming with abdominal pain, vomiting to emergency. What is the feature if present escalates the management? Abdominal tenderness, shoulder tip pain, or guarding? What is shoulder tip pain indicating, guys? Very good. Ectopic, ruptured ectopic, not just ectopic, ruptured ectopic. Good. Irregular cycles, last menstrual period 3 months ago comes with severe vomiting to emergency. After initial resuscitation, what is the next step? Antibiotics, ultrasound, or beta HCG? We need to rule out ectopic, so we will do beta HCG first after initial resuscitation. Very good. Last one. I think we might have done this before as well. Baby is presenting, neonate is presenting at 3rd day with jaundice. Mother is Rh negative. What could be the cause of the jaundice? Rh isoimmunization, ABO incompatibility, immature liver, hepatitis, or breast milk jaundice. Coming at 3rd day. 3rd day, not 1st day. 3rd day of birth, coming with jaundice. The first 24 hours, I agree, Rh isoimmunization would have been your answer. This is physiological jaundice. The cause of physiological jaundice is immature liver. It's not breast milk jaundice, it's physiological jaundice. It's physiological jaundice because of immature liver in the neonates. If it was 24 hours and mom was Rh negative, then consider Rh isoimmunization. If it was first 24 hours febrile and jaundice, then hepatitis. You can look at Radiopedia, Dr. Hogan. Just click Radiopedia and age appropriate investigations for headache. They will tell, they usually have that. Okay. All right. The whole jaundice is in the RCH guideline. It's very appropriate, or you can look for the Queensland Health one as well. So early onset, less than 24 hours is pathological, could be sepsis, hemolysis by isoimmunization, G6PD, hereditary spherocytosis, hemorrhage, or blood extravasation like hematoma. 24 to 14 is physiological because of the immature liver, could be because of dehydration, insufficient feeding, could be sepsis, hemolysis, breast milk jaundice, bruising, and birth trauma as well. Prolonged jaundice, more than 2 weeks persisting, is caused by sepsis, hemolysis, dehydration, breast milk, hypothyroidism. Conjugated hyperbilirubinemia is neonatal hepatitis, biliary atresia, metabolic, or drugs associated with it. We know the assessment. We check for the bilirubin level. We do a normogram and then do phototherapy and exchange transfusion based on that. Third day, most likely physiological. Third day, if you have a look, physiological jaundice, most commonly physiological. Breast milk is diagnosis of exclusion. You have to rule out all of these and then you can say, oh, it's breast milk jaundice. Alrighty. That is all for today, guys. Thank you so much. Where it is. Stop share. I hope you had a good class. I'll let you guys know about when I'm going to be taking the canceled class. But yeah, I will see you guys soon, okay? Study hard and best of luck for those who are taking their exam in the coming weeks or so, okay? Thank you so much. Have a lovely night.